So I went ahead and I started the recording for you guys. So without further ado, let's go ahead and get into some pathophysiology. So I always like to start out with some tips for success. End of chapter questions are really helpful. Creating a custom quiz if you're looking for practice questions. I know in class you do a lot of case studies, so I'd recommend kind of reviewing those. If you're looking for some study guides, Osmosis by Elsevier is very helpful. When we're talking about how to answer the nursing questions, always ask yourself, what's happening with this disease process? What's happening with this situation? What's going on? And how do I educate my patient? I always say the patho behind a disease process, you need to know the patho enough to provide education. Okay, no one's asking you to go nitty gritty into like, well, actually the cells are becoming hypertonic and X, Y, and Z. You really just need to be able to educate your patient in digestible terms what's going on, so that way you can provide further teaching, clarification, etc. Additionally, it's important to recognize your hallmark signs and symptoms. A lot of disease processes have a lot of the same symptoms: nausea, vomiting, diarrhea, lethargy, headache. All of it can become pretty muddled. So what differentiates this disease process from another disease process? More importantly, what do I as a nurse need to look out for? What do I need to incorporate into my assessment? Okay? Beautiful. So, going to talk about Unit 1, the cell, and we're just going in order from the beginning of the semester all the way to now. So let's talk about some cellular issues. The first one we're going to talk about is trisomy 18. This is Edwards syndrome. This is an additional copy of chromosome 18. Unfortunately, while this is compatible with life, the baby will be born, the prognosis is very poor and the life expectancy is pretty short. Essentially, all of their cardiac organ development is pretty delayed. Specifically, congenital heart defects is the big issue with Edwards syndrome. So we do have these clubbed feet. I really want you to pay attention to the heart abnormalities, specifically our ventricular septal defect, our PDA, and our pulmonary stenosis. We'll talk a little bit more about these in our cardiac, but just know that with a lot of our trisomies, even trisomy 21, our Down syndrome, there's a lot of cardiac anomalies that are associated with trisomies, and that's kind of across the board. And talk about cellular adaptation. These are just ways that our bodies can kind of recuperate, etc. I would just know examples of each. So, for example, atrophy, that's when my muscle cells decrease in size. So if my arm was in a cast and I'm not using those muscles a lot, when I take the cast off after 3 months, it's going to be a lot smaller than when it started out. That's our atrophy. Similar to our hypertrophy, this can be our regular, muscles growing when we're working out. Or if my organs have to work extra hard, it can lead to hypertrophy. Think about the heart. If our valves have to work extra hard, they can become bigger and stiffer. Hyperplasia is number. With metaplasia, these cell types are being replaced with a different type. Dysplasia, whenever you think of dysplasia, I want you to think about a risk for cancer, because unlike metaplasia, this is still the same cell that began, but now it's kind of those cells that can turn cancerous. So whenever you think dysplasia, think they're at a little bit increased risk for cancer. So cellular injury and apoptosis. Usually what's causing a cellular injury is going to be our lack of oxygen within the cells. Our cells need oxygen to function, ATP, all of that. What happens when my cell gets damaged or something's wrong with my cell? My cell has an innate mechanism in it to trigger apoptosis. This is just to keep cellular replication in check, okay? So what type of cellular injuries are there? Well, you have your apoptosis and you have your necrosis. When you think apoptosis is a normal programmed cell death, okay? There's a process. Something's going on with my cell. My cell itself recognizes that there's an issue, and my cell is still healthy enough to say, okay, let's terminate. Whereas necrosis almost always is going to be caused by an extrinsic factor like major damage, major reperfusion injury, things like that. Necrosis is going to be irreversible and it causes such damage, but the damage is not coming from the cell itself. With apoptosis, my cell is saying, time to go. Necrosis, this is something beyond my cell. My cell has no control over what's happening. So that's how we can differentiate necrosis versus apoptosis. Water movement is pretty important when we begin to learn how to resuscitate patients with fluids, but just know when we have a hypertonic solution is a salty solution. So if I give my patient a hypertonic solution, it's going to help pull water out. Why? Because salt sucks. When we have a hypotonic, this is what we give to like patients that might be a little bit dehydrated. This is going to help keep water in or push water back in. And finally, our isotonic, this is our normal concentration. So if my patient doesn't require fluid resuscitation and we don't need to take fluids off of them, this is just what's going to keep them at their happy place. So that's isotonic. I'm talking about the ECF versus the ICF. What takes fluid and pulls it into the cell versus out of the cell? Well, it's from osmotic pressures. And as you can see, when we have diarrhea, DI, or adrenal issues, we can see what's going on. And we'll talk about this a lot more with ADH. But just know what's taking the water and taking it out of the cell or putting it back in the cell. That's osmosis. That's where salt goes, water flows. So how do we regulate our sodium and our water balance? Lots of different ways we can, but I really want you to think about ADH and aldosterone, our antidiuretic hormone and our aldosterone. Aldosterone, when you think aldosterone, think kidneys. So what happens? Aldosterone comes from the adrenal cortex, which is on top of the kidneys. And all aldosterone does is it acts on the kidneys to help us save sodium and pitch potassium. So likewise, where salt goes, water flows. So if I'm dehydrated, I want to hold on to salt because I will therefore want to hold on to some water. So that's what aldosterone does. But specifically, aldosterone is going to help us get rid of potassium, okay? Because potassium and sodium are inverse. If I have a rise in sodium, I'm going to have a decrease in potassium. They don't like each other. Salty bananas, you don't put salt on a banana. They don't like each other. We talk about antidiuretic hormone. This is anti-peeing hormone. So essentially, this is released from the brain, and it also does act on the kidneys to just help us reabsorb water and not excrete water through the urine. Now, if I have too much ADH, if I have too much antidiuretic, anti-pee, I'm going to be holding on to a lot of water, which isn't very good. So in the normal day-to-day scenario, if I have a drop in blood pressure, ADH gets released to act as a vasopressor to increase our blood pressure, which is great. We'll talk about a little bit of the pathologies in a little bit. Whenever you think ADH, think anti-pee. It stops us from peeing. It helps us hold water. Again, a little bit more info on aldosterone, but it really just helps us go into our RAS, our renin-angiotensin-aldosterone syndrome, to go ahead and help just increase our blood pressure as well. ABGs, we talked a lot about ABGs before. I would just really know your normal pH, your normal PaCO2, your normal HCO3. While the next generation NCLEX will include lab values for case studies, it's not necessarily going to give you lab values for every single question. So really, I would memorize your ABGs, knowing what is acidic versus what is alkalotic. What's our normal carbon dioxide? I want you guys to remember carbon dioxide is an acid. So if I have lots of carbon dioxide, I'm pretty acidic, okay? Bicarb, think basic. Always look at your pH first. Compensation can also occur, which can be a little bit tricky, but I just want you to know what makes sense. That's what we look about. So I have this example here if you'd like to go through it another time, but just really know that our bodies will try to compensate. If we have an alteration in pH, if my lungs are having a problem and my lungs are causing the situation, if my lungs are causing respiratory acidosis or respiratory alkalosis, my other system will kick in. My metabolic system will try to kick in. If my kidneys aren't functioning enough, and my kidneys are putting me in an alkalotic state, I'm going to compensate with respiratory. Okay, so whatever's not working, the other will try to compensate. So now we're going to talk about mechanisms of self-defense. So our phagocytosis is pretty good in our innate immune response. Essentially, it's a pretty simple process, but essentially our phagocytes are like our engulfing cells that kind of help ingest foreign objects, particles, bacteria. But they recognize that there's a threat, they engulf it, they break it down, and they destroy the target. Pretty simple with phagocytes. When we talk about inflammation and fever, there is a difference between inflammation and fever. With inflammation, we have redness, heat, swelling, and pain. Heat and fever are not the same thing. If I'm having heat, it is localized. If I'm having fever, that's systemic heat. I'm having like heat everywhere, and that's not the same thing as inflammation in one area. So essentially what happens are damaged tissues release histamine. Histamine creates leaky capillaries. When my capillaries leak, they kind of sound the alarm. Phagocytes, clotting factors come and travel to the wound. Additionally, platelets come and help to seal the wound. So our antibodies, a mnemonic I like to talk about is game day, GAMED. So our G's are our most abundant. That's what I would remember. Our A's are more of our mucous membrane, saliva, tears. What I want you guys to know about IgM, immunoglobulin M, is that it's the first antibody made to fight a new infection. So if I'm having a brand new infection and I get my blood count back and I have high levels of IgM, I know that infection's pretty recent. But if my blood shows an increased amount of IgG, I am fighting an infection, but the infection's probably been with me for a little bit. So that's a good tool that we as nurses can use to assess for infection. When we talk about blood groups, I do apologize, I got cut off a little bit, but essentially know that whatever blood type you have the opposite's antibody. So I have type B blood, I have anti-A antibodies. Therefore, if I have type B blood, I cannot receive A blood because my A antibodies will attack that and cause a massive transfusion reaction. When we're talking about our rhesus factor, this is the positive or negative on our blood type, meaning you have it or you don't. Okay, so if I have a positive blood type, I'm pretty much okay. I can receive negative or positive. If I have a negative blood type, let's say I'm B negative, I can't receive B positive blood because I'm going to create antibodies against that positive rhesus factor. Just kind of keep that in mind as well. We talk about hemolytic disease of the newborn. This is if I have type A negative blood and my partner or my husband has type A positive blood, that could cause a reaction because if my baby has a positive rhesus factor, my body might attack it. Now, the first time, it's not enough to do damage, but if I get pregnant a second time, I have already built up some antibodies to that positive rhesus factor. That's why we give pregnant moms Rogam. So for blood typing, we really want to advocate for prenatal care and making sure that they receive this. So that's what hemolytic disease of the newborn is. Lots of different ways organisms can cause infection. They need to be able to, number one, produce disease, but they want to have a pretty low virulence. We don't want them to cause severe disease to where it would kill the host, because then the host can't pass the disease on. So these are just other examples on how organisms can cause infection. Talk about infections. Our common ones are going to be our bacteria or viral. Just know that with bacteria infections, they solely rely on evading the body's defense mechanisms. Bacteria is alive. It's doing its own thing. So our body, all it's doing is evading the immune system, and we treat it with antibiotics. When we have opportunistic infections, these are bacterial infections that usually only occur in immunocompromised individuals, because on the day-to-day, for a normal patient, our body's defense mechanisms will absolutely take it out. Our viral infections, viruses aren't alive per se. They actually require the host cell's machinery. So they hijack our host cell machinery. Unfortunately, not a lot of treatment for viral infections. That's why symptom management is key, but also prevention with certain types of vaccines. So, stress and disease. We have our HPA axis, our hypopituitary axis. Essentially, what happens is that when my brain gets stressed, it releases CRH, which acts on the pituitary gland to produce ACTH. What does ACTH do? Acts on my adrenal gland, produces cortisol. So if we're in fight or flight or we get stressed, my blood sugar is going to be increased because it increases my blood sugar to try to increase my energy reserves. Also, when we on the adrenal gland has your adrenal cortex and your adrenal medulla. So by releasing cortisol, what else is also in my adrenal gland? Aldosterone. We also have our catecholamines that get released too. Unfortunately, with chronic stress, if we have a constant release of norepinephrine, we're going to be at increased risk for stroke, myocardial infarction, etc. But in emergency situations, this HPA axis is good. That increase in epinephrine or norepinephrine will help us with fight or flight. However, with chronic stress, if we're constantly in this state, of stress and we're having this ENNE being constantly released, I'm at risk for some negative health outcomes. Now we're going to talk about the brain, cancer, and some pathos. So what is cancer? So cancer essentially is a dysregulation in cellular reproduction, cellular replication. There's something wrong with my cell, and for whatever reason, instead of apoptosis being triggered, this cancerous cell keeps on reproducing. So, what are our main complications from cancer? Infection is a really big one because it decreases our immune system. So, we have leukopenia, thrombocytopenia, so we're going to be at risk for infection and risk for bleeds. Cachexia, that's more of your anorexia, wasting, etc., pain, fatigue. There's a lot of GI issues with cancer patients that end up leading to malnourishment, hair and skin problems, osteoporosis from calcium deficiencies, etc. We'll talk a little bit more about our Wilms tumor when we get to our kidney, but I just want you to know that the Wilms tumor is a tumor of the kidney, but we will cover that. So, Wilms tumor, again, linked to an early development of the kidney. Essentially, as a nurse, what do I need to know? This is an encapsulated tumor of the kidney. So what do I need to know about tumors that are encapsulated? I don't want to palpate the abdomen. Why do I not want to palpate the abdomen? I could essentially pop that tumor, and what was once encapsulated is no longer encapsulated, and it can go through the bloodstream, and that's a big issue. These are more prevalent in pediatrics. We're going to flip it a little bit to our brain. So what is our intracranial pressure? It's just pressure exerted by stuff in the brain. What's in the brain? Our cerebrospinal fluid and our brain tissue itself. Our brain is a closed box, meaning if I have swelling in my brain, there's not a lot of area for my brain to adapt. Whereas if I break my wrist, I can have lots of swelling because I have skin and there's nothing surrounding my wrist. That's why our head injuries are very serious, because as my brain begins to swell, there's no place for it to go. So it's eventually just going to start crushing portions of my brain, and when we start seeing the swelling that goes down to the brainstem, that's when we see severe neurological deficits, when you start seeing that decorticate and decerebrate posturing. So you might at first see these changes, these subtle changes in your LOC. Now their Glasgow Coma scale is dipping a little bit lower and lower. You might have some headaches. Then you're going to start seeing issues with their eyes, and then eventually you're going to start seeing some posturing, some headache, seizures. Specifically, Cushing's triad, that's when they're going to have an increase in blood pressure, specifically our systolic blood pressure. So the number on the top is going to be very, very high, but my heart rate's going to be pretty low, which when you think about patho is a little bit odd, because usually if I have a drop in blood pressure, my heart rate's going to try to compensate. Those are trends we're used to seeing, but now all of a sudden you have this decreased pulse, but for whatever reason, my systolic blood pressure is crazy. That's because our autonomic nervous system is in our brain, and if my brain is being squished and crushed, it's dysregulated. And finally, you're going to see decrease in respirations. Why? Brainstem's got our respiratory control center. MS, multiple sclerosis, this is a chronic immune-mediated inflammatory disease. What's important to know about multiple sclerosis is that it eats away at the myelin sheaths. Myelin sheaths help submit nerve impulses. So if I've eaten away at my myelin sheath, instead of having a nice lubricated road, I have a bunch of potholes in my road, okay? And it's not going to travel as well if I have lots of breaks and holes and whatnot. So actually on a scan, you will see plaques, which are missing pieces of their myelin sheaths. So you'll see a lot of muscular issues, sensory issues, specifically urinary incontinence with these patients as well. It's important to prevent exacerbations, because once they have an exacerbation and the myelin sheath has been attacked and eaten, they're not going to go back to their baseline function. Lou Gehrig's disease, this is our disease with probably the worst prognosis. They have about 3 to 5 years to live, but essentially what's happening is I have massive degeneration of my motor neurons. My mind and my muscles can no longer communicate, so essentially they're going to have loss of function in all of their muscles that eventually leads to paralysis, total paralysis, and for these patients, eventually resulting in respiratory paralysis and death. So that's what ALS is, and unfortunately there's no cure. You might also hear it as Lou Gehrig's disease after the baseball player. Myasthenia gravis, this is another autoimmune issue, but essentially my body's attacking my acetylcholine receptors, and acetylcholine is a neurotransmitter that helps us with motor movement. So if I'm attacking my acetylcholine receptors, I'm having decreased acetylcholine receptors, so now my body has to work extra hard just to make a movement happen. So usually you'll just see some issues with like weakness, tiring, etc. The specific about myasthenia gravis is that we have a lot of eye symptoms as well. So you'll see some diplopia, etc. It's really important that these patients continue to take their medications, because if they don't, they could experience their myasthenic crisis, which is when we don't receive our medication, and all of a sudden we become very, very hypertensive, our heart rate's out of control, and we're going to have difficulty breathing. So I just remember that for our myasthenia crisis. Our main neural tube defects are defects of neural tube closure. In utero, our spina bifida occulta, this is our most mild form. It's going to be the one on the far left. Usually you'll see like a little bubble or a little dimple on their back. A meningocele, this is sac-like. It has some of the meninges and spinal fluid in it. Our myelomeningocele, that's our worst, because there's actually pieces of the spinal cord in this protrusion, which can result in paralysis and severe neurological issues. So moving on from the brain, we're now going to talk about the endocrine system, which is very related to the brain. Our pituitary gland, this is located in the middle of the brain, and our main function of our pituitary gland is to produce ADH, antidiuretic hormone, our anti-P hormone. So what are some alterations in pituitary function? Well, our first one is going to be SIADH. So think big and bloated, soaked inside. Essentially, I have so much ADH being secreted, my body's going to hold on to so much water. What happens when I hold on to water? My blood pressure increases. I'm in fluid overload. And because I have all this fluid being increased, it's going to throw off my ratio. So I'm going to be pretty hyponatremic. With this hyponatremia, that's an electrolyte imbalance. What do we know about electrolyte imbalances? They mess with the brain and they mess with the heart. So now we're having a lot more issues. What's interesting about these patients is their urine will be very, very concentrated, which is odd because you would assume that only dehydrated patients have concentrated urine. Well, technically, these patients are they're tricked into thinking they're dehydrated because ADH gets released when we're dehydrated. So that's just something to keep in mind. And then seizures is a big one. Diabetes insipidus, think dry inside. So I don't have enough ADH. So essentially, whatever water I have or whatever water I put in, it's going right out with these patients. We have neurogenic DI versus nephrogenic DI. With neurogenic, think a problem with my brain. Whereas if I have nephrogenic DI, this just means there's a problem with my kidneys. Maybe my kidneys just aren't receptive to ADH being produced. But a neurogenic problem would be my brain simply not producing any ADH. And the only way to treat diabetes insipidus is to give us vasopressors. For diabetes mellitus, I would just know your normal lab values, your normal ranges for glucose, etc. What would be hypoglycemic, what would be hyperglycemic, etc. Included this slide how the body manages glucose, just for you guys as well. Type 1 diabetes, this is an autoimmune issue where my body simply does not produce any insulin. So what do I need to do? I need to give them insulin. This is when we're at more risk for our weight loss, diabetic ketoacidosis, etc. Whereas our type 2 diabetes is usually linked to lifestyle issues. Essentially, I just might not produce as much insulin, or my body's just not sensitive to insulin anymore because I've had a sustained diet high in sugars. So our type 2 diabetes management, a lot of it's going to be like dietary lifestyle changes. Now we're going to talk about our thyroid disorders. Our main thyroid disorders are going to be our hypo versus hyperthyroidism. But what I want you to know, thyroid hormone gives us energy. Okay. So, hypothyroidism, I have a deficient production of thyroid hormone by my thyroid gland. Now, I do want to go back to this slide and I want to point a few things out. So, my brain releases TSH. If my body senses that I don't have enough thyroid hormones and I don't have enough energy, it's going to release TSH. Thyroid stimulating hormone acts on the thyroid. And after acting on the thyroid, it's going to produce T3 and T4, our big energy items. So with our hyperthyroidism, what's happening is I have antibodies against my TSH receptors. So essentially, again, going back to this photo, if I have antibodies against my TSH receptors on my thyroid hormone, essentially, these antibodies keep hitting the thyroid and working on the thyroid. Well, what does my thyroid do? Produces T3 and T4. So if I have too much action happening on my thyroid, that's what's going to cause the T3 and T4 to be produced. Essentially, it's like throwing darts at my thyroid, bing, 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 hitting the thyroid. What am I getting? T3 and T4. So that's hypo versus hyperthyroidism. A very common hyperthyroidism is our Graves' disease. So again, autoimmune disease, these antibodies attack my TSH receptors, which is on my thyroid gland. So what happens? Essentially, I'm going to have increased activity happening on my thyroid hormone. And I'm just going to be having increased energy because that's what T3 and T4 do. They give us energy. So essentially what's happening here is that I'm going to be having a lot of increased heart rate, weight loss. I'm going to be very, very sweaty, etc. And I'm going to have a lot of localized edema too. What's really common in these is our exophthalmos, our bulging eyes. It's also called our thyroid eye disease. So moving on, let's talk about our adrenal gland. So our adrenal gland is found on top of each kidney. You have our adrenal cortex, which ends up getting stimulated by ACTH. And what does our adrenal cortex do? It helps us with the production of our glucocorticoids, okay? Our adrenal medulla, on the other hand, this is what's going to produce our fight or flight hormones. So what are fight or flight? That's our epinephrine and our norepinephrine. That's just kind of our adrenal gland in a nutshell. When we talk about issues of the adrenal gland, we have our Addisons and our Cushings. So Addisons, we don't have enough cortisol. We don't have enough aldosterone. So I'm going to have a lot of hypotension, a lot of wasting, GI problems, weakness, etc. With an Addisonian crisis, this is when my blood pressure becomes hypotensive. Okay? With Cushing's, this is our hypercorticolism. It can be caused by a couple different issues. Essentially, if I have way too much cortisol, that can happen naturally in my body from other disease processes, if I have swelling in my brain, etc. Or if I'm taking a lot of drugs that have cortisol, corticosteroids, etc. So I would just kind of review that, what's common with our Cushing's, that truncal obesity, hyperglycemia, etc. So again, I kind of relayed out the two of them, but really what's going on with Addison's, this is autoimmune that's happening, destroying my cells. With our Cushing's, again, we can have excess steroids, abruptly stopping steroids, etc. I'd review your hallmark signs and symptoms too. Now we are going to talk about blood. So what is a shift to the left? If I am having a infection, I'm going to release whatever I have, even if that includes immature neutrophils, okay? So if I have a lab work done and I show a left shift, it means my body's fighting a pretty new infection. So if you come into the hospital and you see a shift to the left, maybe 4 or 5 days later, we want to redo the neutrophil test. And if we see a shift to the right, it means we're returning back to normal. Okay.
We can't see the slide.
Oh, I'm sorry. Let me see if I can. Do you see it now?
I can see the slide. It might be their connection.
Oh, okay.
Sorry.
It's okay. Do you guys see sickle cell anemia?
Yeah.
Okay, perfect. All right. Thank you for the thumbs up. Thank you. So with sickle cell anemia, essentially I have an HBS trait. You will actually see, like if someone's marked with sickle cell anemia, it'll say capital H, little b, capital A, capital S. Okay, so this is an autosomal recessive caused by a mutation in HBB. So instead of reading HBB, I'm going to see HBS. Okay, so what happens? These red blood cells sickle. When they're sickled, they don't travel as easily, and this can cause vaso-occlusion. It can cause clots, okay? Usually it's pretty well managed, but what we have is our sickle cell crisis. So this is severe pain brought on by hypoxia, acidosis, high altitudes, or dehydration. So I want you guys to look at the little frog on the screen. Treatment is hop to it. So how do we treat this? We give them lots of fluids, lots of oxygen, and reduce their pain because they'll be in pretty severe pain from the sickling, resulting in temporary hypoxemia. etc. So that's why we want to give them some oxygen as well. But a lot of sickle cell anemia, a lot of our crises are brought on by like massive dehydration, temperature changes, going in an airplane, etc. So thrombocytopenia, this is related to our platelet counts. What do our platelets do? They help us form clots, okay? So if I have a decrease in platelet count, I'm going to be at increased risk for bleeds. Certain drugs, infections, renal disease, cancers can cause thrombocytopenia. We learn a lot more about thrombocytopenia in Complex Health 1, but just to get a basic, here are your lab values. If I am less than 100,000, I'm at risk for bleeds, but as that number gets smaller and smaller and smaller, I'm at really big risk for bleeds. So what am I as a nurse going to do? I'm going to advocate for my patient for safety, probably fall risk. If they shave, use an electric razor. If maybe is now just not the time to play contact sports. So that's what we're really concerned about with thrombocytopenia is bleeds. Now we're going to talk about our cardiovascular and lymphatic system. So what in the world is Virchow's triad? Well, in order to assess my patient's risk for a pulmonary embolism or a blood clot, I'm going to look at Virchow's triad. This is what's going to put my patient at risk for developing a blood clot. So there's three components: our hypercoagulable state, vascular wall injury, and circulatory stasis. Pretty much almost every patient you care for is at risk for blood clots. Number one, they're in the hospital. They're simply not moving as much as they're used to. But number two, look at trauma or injury. Think on a little bit of a smaller scale. Maybe it's not your car accident patient with multiple abrasions, but what about a patient that just has an IV in? That's technically a vascular wall injury, so that puts them at increased risk for clots. Also, instances of increased blood viscosity. Lots of trauma is going to generate a lot more red blood cells to the area. Sepsis ends up putting us in a massive hit situation where it's going to promote viscosity, and even pregnancies, malignancies, all of that. So this is what puts our patient at risk. So the more boxes they check, the more at risk they are for developing a clot. So I also broke up how to kind of differentiate thrombus, a thrombus versus embolus, because this was something that I simply struggled with. But when you think it's a thrombus, it's a blood clot that forms and slows down blood flow. So a thrombus occurs at the site of where it developed, okay? That's a thrombus. A DVT, deep vein thrombosis. That's like that blood clot in the veins of the leg. Whereas our embolus, this is an obstruction of blood flow by anything, okay? Whether maybe they had massive trauma and glass cut them and they have a little piece of glass that's traveling. That would be an embolus. A thrombus that moved from its original location. Now we're more of an embolus, okay? You can also differentiate them between venous and arterial just based on where it's lodging and what's happening. As we know, our arterial thrombosis are a little bit more serious because what do arteries do? They provide blood and oxygen to the rest of the body. So if that's blocked, I have a problem. Thrombophlebitis, this is a swelling of a vein, again, usually caused by blockage such as our clot. They're really going to present with swelling, tenderness, pain, and warmth. So when we talk about hypertension, lots of issues. Again, this is really covered in Complex Health 1, but for you guys, I want you to focus on what are some of the complications and what are some of the risk factors. Main risk factors: family history, alcohol, smoking, obesity, really big one. Also think of your environment and your epigenetics. As you can see, laundry list of complications, specifically heart failure, renal issues, stroke, aneurysm, hemorrhage, all the above, okay? So we reviewed our clots. Well, what is a pulmonary embolism? So pulmonary embolism is when a blood clot gets stuck in the lungs. That's why when our patients are on DVT prophylaxis, we're really concerned if they have a history of clots, because if that clot becomes dislodged and it begins to travel, the organ of choice that they just love to lodge in is our lungs, which makes sense when you think about it. When you think about our blood flow, it goes out throughout our body, it goes up into the right side of the heart, into the lungs, into the left side of the heart, back out through the body. So naturally, it makes sense that it's going to land in the lungs. So usually these patients will present with apprehension, nervousness, anxiousness, shortness of breath, chest pain, pulse. Bloody sputum is really common, and fainting as well. So mitral stenosis, this is narrowing, stiffening of the mitral valve. So what in the world does mitral valve do? It helps us bring blood from the left atrium to the left ventricle. Where does it go after the left ventricle? It goes out the aorta and into the body. So that can be a major issue. What's interesting about mitral stenosis is that usually patients that present with mitral stenosis have had a history of rheumatic fever, just because that infection likes to kind of aggregate on the mitral valve, which is interesting. We talk about our ejection fraction. This is how much blood leaves the heart each side it contracts. And what does blood have? It has oxygen. So I need a good ejection fraction in order to perfuse all of my organs. So I just want you guys to know that it is our stroke volume minus our N over our end diastolic volume, and it'll be in percent form. So just remember that. So what is HREF versus HPEF? So HREF, this is reduced ejection fraction. So what am I concerned? I'm concerned that I'm not perfusing my organs as well. So again, it's usually going to be more indicative of like systemic, like heart failure, systemic organ damage, things like that. However, if we have heart failure with a preserved ejection fraction, while I do have heart failure, it isn't affecting my ejection fraction, and therefore the rest of my organs still theoretically could be getting produced really well. But I think for you guys, what's just important to know is know your normals for ejection fraction. We want it 55 to 70. For less than 40, that's when I'm really, really concerned, and I might need to put them on advanced drug therapy, such as pressors. Okay? So myocardial ischemia and myocardial infarction are very different. However, myocardial ischemia can lead to a myocardial infarction. So essentially what's happening with myocardial ischemia is that lack of oxygen to the muscles of the heart. And essentially my heart releases a little bit of pain because it's crying out, because it's like, ow, this hurts, I need oxygen. So that's what's happening. Usually it's going to be in relation to activity. So if they have overexertion, they're going to have a little bit of chest pain, which should stop once I begin resting. However, if I have chest pain that is unrelieved and it keeps going and it keeps getting worse, now I've tiptoed into an infarction. Okay, so this is actually death that results. Heart tissue, because my heart tissue simply did not get enough oxygen. And this is why it's really important at the onset of unrelieved chest pain that these patients get to a hospital. And our goal in the hospital is that from the time they get to us, we need them up into surgery within 1 hour to remove that blockage, because this tissue death does occur over 4 to 6 hours, okay? Just to keep that in mind. So we talked a little bit about left heart versus right heart. And just a quick little crash course. The right side of our heart gets blood from the body and it takes it to the lungs. Our left side of the heart gets the blood from the lungs and it takes it to the body. So if I'm having issues with the left side of my heart, it's going to cause a backup of blood. Where's my blood going to back up into? It backs up wherever it came from. So if I have issues with my left side of the heart, where did it come from? The lungs. So I'm going to have lung symptoms. Whereas if I'm having issues with the right side of my heart, where did it come from? The body. So my symptoms are going to be in the body. And that's how you can kind of know both. So again, we're really concerned with left-sided heart failure because it can ultimately lead to right-sided heart failure, because if it goes through the lungs, pushes back into the right side of the heart, it causes the right side of my heart to work extra hard. Again, another little review of heart failure, etc. So when we talk about shock, there's multiple different types of shock. But what I think is important for you guys to know is that no matter what type of shock, my patient will always present with a drop in blood pressure, okay? And because I have a drop in blood pressure, my heart is going to try to compensate by increasing the heart rate to try to get more blood out there, okay? Lots of different causes: trauma, allergic reaction, infections, burns, etc. Hypovolemic, that's inadequate fluid volume. Cardiogenic, that's a pump problem. My heart isn't pumping well enough to give me a good blood pressure. Neurogenic, this is an issue with the brain. Anaphylactic, this is allergic reaction. And septic, this is infection. Okay. All forms of shock can lead to MODS. So what is MODS? Multiple organ dysfunction syndrome. Usually you need about 2 organ systems to stop functioning to be qualified as MODS. Usually our kidneys are our first to go. Our kidneys are little divas. If they're not getting the blood and the oxygen that they need, they're going to stop working and they're going to fail pretty quickly. They're very finicky organs, so we have to be really careful with our kidneys. But essentially, any patient that's had cardiac arrest, any patient that's had massive trauma is at risk for MODS, okay? Because however long they were down or however long they received inadequate perfusion, that can cause lasting damage on my organs. So again, risk factors: sepsis, burns, COVID patients, disease, etc. Dysrhythmias, this is just an abnormality in my heart rhythm. So usually we have our normal heart rhythm, but with a dysrhythmia, it's just going to look a little bit odd. It can be too fast, too slow. It can just look wonky. It's not important for you guys to know the different types of dysrhythmias because, again, we really go into that in complex 1 and 2. But it is important to know that with any sort of dysrhythmia, they're at risk for cardiac complications, okay? And always assess your patient first if they're having a dysrhythmia on the EKG. So let's talk about our pediatric population. So our most common alteration is our ventricular septal defect. Essentially, there's a little hole in their heart that separates the 2 ventricles. Most often, it will cause pulmonary hypertension. I also drew this little photo for you guys because I think this kind of helps picture it a little bit more. Yeah, so you see that there's this little hole between the right ventricle and the left ventricle. That blood will get pushed back from the left ventricle, and now my right side of the heart is overfilled with blood, so now my lungs have to work extra hard. That's what leads to the pulmonary hypertension because I have increased blood flow going through my lungs. So that's kind of how you can picture it. Our signs and symptoms are related to the left to right shunt. So that's why you're going to see a heart murmur. They're going to have poor feeding, etc. Our Tetralogy of Fallot, think tetra, think 4 things are going on. They have a large ventricular septal defect, overriding aorta, pulmonary valve stenosis, and right ventricle hypertrophy. Some things that can occur with these patients, and by causes, I mean Tetralogy of Fallot will cause acute cyanosis at birth. It will cause TET spells. In order to compensate for this hypoxia, these kiddos actually will put themselves in the tripod position because they simply find it easier to breathe. Okay. And yeah. You'll also see from this chronic hypoxia clubbed fingers, polycythemia, and increased H&H. The reason that we see an increased H&H in these patients as well as our COPD patients is because if they're having frequent reoccurring hypoxic issues, my body's going to recognize that. It's going to say, hey, there are some times where I'm just not getting enough oxygen, and I don't like that. So it's going to increase H&H, hemoglobin and hematocrit. Those are oxygen-carrying proteins. So my body's like, well, let's raise our oxygen-carrying capacity so that I can try to combat this hypoxia. So that's why they have an increase in H&H. But what are we concerned with? Now their blood is a little bit more viscous. Now they are clot risk. So that's an interesting thing about H&H. Coarctation of the aorta is another issue. It really results in decreased cardiac output. What I would know about coarctation of the aorta is that upon assessment, before this coarctation point in the upper body, you'll have a really high blood pressure, but then if you go to take their blood pressure on their leg, it'll be a lot lower, and they might be exhibiting like inadequate perfusion of the leg. So that's something that's interesting too. Again, you have your upper extremities are being more hypertensive and your lower extremities, low blood pressure, etc. Eventually, it can lead to some heart failure as well. So now we're going to talk about the lungs, the great lungs. So our hypoxemia, that's decreased oxygen in the blood, okay? It can be caused by issues with oxygen delivery to the alveoli, poor diffusion of oxygen, whatever. Our hypercapnia, that's when we build up way too much CO2. Remember, we inhale oxygen and we exhale carbon dioxide. So what might cause me to build up CO2? Well, if I'm not exhaling, what specific things can cause me to stop exhaling? Certain drugs, overdose. If I have a head injury and my respirations are off, it can cause a buildup of CO2, which is a really, really big issue. So I would just kind of review that. What's our normal CO2? It's 35 to 45. If we start seeing 50, 60 CO2, that would mean my patient is hypercapnic. So, what is flail chest? Essentially, this is very common in our patients that have had multiple rib fractures, usually like 2 or 3 on the same side. But essentially, they've had so many rib fractures that air will get in and it'll throw everything off. So they'll end up having this paradoxal movement. So if you think back to health assessment, what we did is when we went on their back, we put our fingers together just like this. And when we had them breathe in, both my hands would move at like an equal distance. But if I have flail chest, I might see one move in and one cave in. It's not going to be even, okay? So that's what we have, paradoxal breathing, really common with trauma patients. Our pleural effusion, this is fluid in my pleural space. As you can see in the photo below, as fluid increases, it compresses my lung. What happens if my lung gets compressed? It can't hold in as much oxygen. So our concern is oxygenation. So lots of causes: heart failure resulting in pulmonary edema, and pneumonia as well. They're going to have a lot of pain when inhaling, shortness of breath, and wherever the fluid is accumulating, if it's accumulating in the left lower lobe, if I auscultate the left lower lobe, I'm not going to hear really anything, because whenever you have fluid collecting in a space, you're going to have diminished sounds. And if you percuss, it's going to be pretty dull. So what's the difference between acute lung injury and ARDS? So with an acute lung injury, this is really an injury. I'm going to have infiltrates on my lungs, but it's not necessarily super severe, and there's not this mass amount of inflammation. When you think of ARDS, this is an injury to the alveoli. What is the function of the alveoli? The alveoli is the site of gas exchange. So at the alveoli, blood goes to the alveoli. The alveoli take out the CO2 and they put in the oxygen. That's what our alveoli do. But with ARDS, my alveoli become so fluid filled with gunk, infection, fluid, if someone drowned, fluid, to the point where my alveoli no longer have any room to take blood and convert it to carbon dioxide. So they're going to have refractory hypoxia, meaning that if I put them on a non-rebreather mask and I crank their oxygen up to the max capacity, their O2 stats will not change. This is because it's not an issue with oxygenation, simply my alveoli can't do the work. So a patient in ARDS will need to be intubated because they are unable to keep oxygenation. And that's why we put them on a PEEP ventilator to try to pop open the alveoli. But this is a medical emergency. Again, I talked a lot about that refractory. What does refractory mean? It means that they're still going to have hypoxia no matter what intervention I do. Okay? Acute lung injury is just less severe. Okay? Asthma, this is an inflammatory disorder that ends up causing my airway, trachea to close. Usually it's in response to a trigger. Our signs and symptoms are going to have wheezing, shortness of breath, etc. What I want you guys to know about asthma is that we learned, I think, in your patient-centered care class, you learned a little bit about inhalers. But if someone's having an asthmatic attack or an asthma attack, they need to get their short-acting beta agonist, their SABA, albuterol. Albuterol is what they do to open up their airway. Also, if you're treating a patient with asthma and you did your auscultation and you heard some wheezing and you went to the computer, you documented wheezing, and then all of a sudden you're looking at their stats and they seem to be trending downward, and you go auscultate again, and now you hear no wheeze, that's a medical emergency. And the reason why is when you're hearing the wheeze, that's because their trachea is becoming narrow. But if I no longer hear that wheeze anymore, that means that my trachea has completely closed off. And this is, again, a really big problem. We need to open up that airway as fast as we can. Okay? Another common issue in the hospital is pneumonia. This is why we want our patients using their incentive spirometers. We are getting them up to the chair. We are getting them up out of bed, doing the whole thing. But with pneumonia, again, our alveoli can fill with pus and fluid. And as we talked about with ARD, the more pus, the more fluid that accumulates. If it completely fills up my alveoli can't exchange gas. And that's a problem. Multiple causes: aspiration, ventilators, community-acquired pneumonia, hospital-acquired pneumonia, a lot. What I want you to know is that usually you'll see an acute change in level of consciousness. Maybe your patient was cool, calm the whole shift, and now she doesn't know where she is. She's trying to fight you. She's agitated. She's grumpy. She thinks she's on planet Mars. I would think pneumonia. And why are we having these neuro issues? Well, inadequate oxygenation, I always think neuro. My brain's not getting enough oxygen up there. Okay. So, COPD, big problem because it's composed of two different pathologies. Both our main risk factor is smoking and tobacco. This is why we educate on smoking cessation a lot. So what's happening with chronic bronchitis? Chronic inflammation of my bronchi and my bronchioles. My emphysema, this is when I have decreased lung elasticity and hyperflation in my lung. So usually I can take a deep breath in and out, and I can breathe out pretty easily because it's just the differences in pressure. If we kind of think of physics, what goes in comes out. Okay, you have that negative pressure situation. But with emphysema, my lungs are so hyperinflated that when I inhale, instead of contracting to exhale, they're kind of just going to fizzle out, and it's not going to give that good squeeze out. So that's what's happening with emphysema. That leads to a buildup of carbon dioxide. So I would just know, sorry, our COPD is composed of our chronic bronchitis and our emphysema. And what does COPD often result in? It results in hypoxemia and hypercapnia, just like the slides I had before. So, pulmonary hypertension. This is when I have, again, too much blood flow going through my pulmonary valve. So, if I have way too much pressure happening, it will cause my right side of my heart to work extra hard to pump the blood through. When we talk about hyperplasia, if the right side of my heart has to work extra hard, just like if I go to the gym and I like work out like my one arm a lot, that arm's going to become big and stiff and all of that. We don't want that with our heart. If we have a really stiff valve, it's going to lead to heart failure. So that's what our cor pulmonale is. That is when I have a right ventricular hypertrophy from pulmonary hypertension. So my pulmonary hypertension led me to right-sided heart failure. And that, in a nutshell, is cor pulmonale. Epiglottitis, this is our inflammation of our upper airway. It's almost always caused by our Hib infection, really common in kiddos. What I do need to emphasize is if you suspect epiglottitis, they are drooling, they are in tripod, their voice is muffled, do not examine their throat. Do not touch anything in their throat. Do not take a tongue blade and stick it down their throat. This can cause a laryngospasm, which will lead them into respiratory collapse. So really, our main focus of epiglottitis is if you know your patient has had a history of HIB, human influenza type B, and they are coming in for like respiratory problems, we are not touching the throat. Great. Another common respiratory issue that affects our kiddos is our cystic fibrosis. This is an autosomal recessive disorder that ends up messing up our chloride ion transportation, which causes our body to hold on to a lot of thick, salty secretions in our lungs. So these kids will usually require extensive chest physiotherapy. They're also going to have poor growth. Their skin will also taste salty, just because they simply can't seem to get rid of this like chloride ion issue. But really, it's a main respiratory concern, and you'll see a lot of issues with these kids, and they won't develop normally. Now we're going to talk about our renal and our urological system, so kidneys and all that fun stuff. So we talk about UTIs. How do we differentiate them? We differentiate them. You have your lower UTI and you have your upper UTI. So when we think lower UTI, this is our bladder, our urethra, etc. Very common, usually E. coli, because E. coli is found in the stool, etc. Our upper UTIs are a little bit more of an issue because the closer you get to the kidney, the more at risk you are for kidney injury and kidney damage. So if you have an upper UTI, usually it's because your lower UTI was untreated and it progressed upwards. It's headed north. So, acute pyelonephritis. This is when I get an infection of my ureter, renal, pelvis, etc. Infection in my kidney. Again, this is what happens when my lower UTI becomes an upper UTI and it travels up to the kidney. It causes massive inflammation in my kidney, which is really, really bad because my kidneys do so much. They help manage my blood pressure. They help excrete toxins, filter out waste, produce urine, and if I have any damage to my kidneys, I'm going to have very bad outcomes. Okay? Hydronephrosis is what happens when I have lots of fluid building up in my kidney, and all that fluid's going to cause a lot of pressure and it's going to damage my kidney. So just like our infection in the kidney, still going to create damage in the kidney, which is not a good thing. Usually our most common cause is either a stricture around the ureter or a kidney stone. And again, as you can see in the photo, as more urine begins to not be able to be excreted, it's just going to back up into the kidney, and that's not good. So when we talk about some acute kidney injuries, we classify them based on what/where is affecting the kidneys. By this, I mean what is causing my AKI. If I have a pre-renal injury, it's not necessarily related to my kidney per se. My kidney's fine. It's just my kidney's not getting what it needs to be supported. So usually renal hypoperfusion. We talked a lot about MODS. If I just didn't give my kidney enough oxygen and nutrients, it's going to cause an acute kidney injury. That would be pre-renal. When we have intrarenal, this is direct injury to the kidney. Whether you have a kidney infection, drugs that are nephrotoxic, tumor of the kidneys. Heck, if I had blunt force trauma to my kidney, that would be an intrarenal injury. And then finally, post-renal. This is what we talked about, like our obstructions, our kidney stones that end up causing a backflow of urine into the kidney to damaging my kidney. So that's how we classify our kidney injuries. Renal failure, on the other hand, we're now going to be looking at our GFR, our glomerular filtration rate. All that big fancy word does, it measures how well our kidneys are functioning. So if I'm at 90, that's great. I'm filtering a lot, and that's wonderful. If I have a lower number as my GFR, that means I'm not filtering a lot, meaning my kidneys aren't working enough. So if we have acute renal failure, this is a rapid decline in kidney function, meaning my patient earlier today was doing fine, and now all of a sudden his numbers are really bad. And usually with acute renal failure, we can kind of go back, treat it, fix it, etc. Whereas our chronic renal failure, this is over time, my GFR gets lower and lower and lower. And unfortunately, with chronic renal failure, as my GFR decreases, it won't ever go back up to baseline function. Usually, our hypertension and diabetes are the number one cause of chronic renal failure. So, what is renal insufficiency? So, this is a decline in our renal function, okay? Again, ideally, we want our GFR between 90 and 100. Those are like good numbers. But with renal insufficiency, we'll have anything as low as 20 to 30, okay? So I'm not functioning as well. So I'm starting to see this buildup in toxins. I'm not going to be excreting as well. All of my fluid and electrolytes are going to be increased because my kidneys aren't doing what they need to do. Okay, and when we get below 10, that's when I am in end stage kidney failure. Kidney stones, we talked a little bit about them before. Just know that a lot of your risk factors are going to be diets high in salt, sugar, and protein, multiple different types of stones. You have your struvite stones, uric acid stones, etc. But just know, if I have a kidney stone, I'm at risk for hydronephrosis and damage to my kidney, especially if it's a struvite stone. Those are usually more like infectious. So I'm really concerned for damage to my kidney. When we talk about pediatrics, usually our pediatric patients aren't going to have that chronic renal failure, okay? Because that's like associated with, long-term diabetes, smoking, alcohol, etc. But what is common with our kiddos is what's called PKD. This is an autosomal dominant disorder, so it is a little bit more common, but essentially my kidneys become filled with these pusty cysts that end up just damaging my kidneys over time. And again, it is autosomal dominant. The more cysts build up, the less of an ability my kidneys will have to filter. And that's the whole function of kidneys. My kidneys help us to filter. Okay. So another issue with like our kiddos' bladder, kidney, UTI tract is our hypoplastic kidney. So that's going to be the picture in the upper corner. That's just an abnormally small kidney. So as you can see by the blue part, look how nice, healthy, large kidney that is. And then you look at it on the right, and it's a lot smaller. That's a hypoplastic kidney. Really, later on in life, we're more concerned with renal disease. But fortunately for a hypoplastic kidney, like we have kidney donors that do fine and well just with one kidney, one functional kidney. So really what's important for hypoplastic kidneys, just to make sure you're taking care of the kidneys that you do have, not using nephrotoxic drugs, having a nice diet that's not high in salts, maintaining a stable weight, managing blood pressure, all of that stuff. When we have renal agenesis, this is when I simply have an absence of my kidney. If I'm missing one, I can get around, but if I'm missing another one, it's a really big problem. When you have your UPJ obstruction, This is usually when this stricture forms and really narrows and compresses my ureter, which again causes that backflow of urine into the kidneys, which then causes damage to the kidneys. So usually for a UPJ, what we can do is we can put a stent in to open it, or we could actually put a drain directly into the kidneys and attach it to a urine ostomy bag on the out and be okay. And then finally, our bladder outlet obstruction. This is a functional issue. Essentially, at the base of the bladder, there's a blockage. And then what do they do for treatment? They just go and they open it back up. We talked again a little bit about Wilms tumor in the beginning, but just know it's a disorder of the kidney, and we do not palpate the kidneys. What you might notice with these kids, if you go to kind of like do an assessment on their back, you'll see like one side that's like really bulging, and you might even be able to like see it. And by palpate it, I mean you can kind of like put some nice little pressure on it, but don't go in there and start like pressing on it. Again, it can be inherited or sporadic as well. Up next, we're going to talk about our reproductive system. So when we talk about issues with puberty, we can classify them two ways, as precocious or delayed. So delayed, we're having puberty happening a little bit later than it should. Usually though, our delayed puberties are a bit more common and less severe, okay? For females, this is classified as no breast development by 13. The breasts are the first thing to kind of form. So with delayed puberty in females, they're not going to have breast development by 13. Usually it's related to like autoimmune issues, underweight, or simply just your late bloomers, and that's okay too. Our males, again, males develop a little bit, females mature quicker than males. So with males, now we're having no puberty by 15. How do we classify this? Is there's no testes enlargement, okay? Again, usually normal, but you'll see this HPG axis a lot. This is what kind of helps produce our hormones. We start talking about precocious puberty. Now we're having a little bit of not a little bit, we're having a medical emergency. So for females, if they start having sexual maturation before 7, it's usually linked to a CNS lesion, chemical exposure, sometimes obesity, but this puts the females at an increased risk for cancer. If my males start to have puberty before 9, this is very rare, and it's again usually due to a lethal CNS tumor, like brain. Okay. So for females, we're going to talk about menstruation. So dysmenorrhea, that is painful menstruation, usually associated with prostaglandin release. That's a primary. Prostaglandin release is a normal part of menstruation, but when we start talking about secondary menstruation, now we have a pathological disorder that's causing this pain. So it's much more than just our prostaglandin release, such as ovarian cysts, endometriosis, etc. Our AUB, abnormal uterine bleeding, this is when we have odd patterns of bleeding. So maybe if they're lacking ovulation and pregnancy or underweight and they're just spotting a few times at different points in the month, that would be abnormal bleeding. If a postmenopausal woman starts having abnormal bleeding, we do want to advocate that they can get it checked out because it might be something a little bit more serious. One of the most common female diseases or disorders is going to be our polycystic ovarian disease. We really don't know the cause, lots of different links. But how do we diagnose it? They're going to have a menstrual cycle without ovulation. They're also going to have increased androgen levels. What are androgens? Testosterone. So that's why these patients might present with like a deeper voice, hair on their face, etc., and difficulties ovulating. Okay. Most of our treatment is going to be aimed at diet and exercise. Pelvic inflammatory disease usually is preceded by an infection, specifically chlamydia or gonorrhea, if left untreated. Again, our risk factors are going to be mainly sexual based. So what are some signs and symptoms? They're going to have a lot of pelvic pain, especially during intercourse. And if, again, it gets left untreated, they can have infertility and ectopic pregnancies. Endometriosis, this is an issue with my endometrial tissue outside the uterus. On the normal day-to-day, our endometrial tissue responds to hormonal fluctuations. It's very active. Usually these signs and symptoms are going to have really bad pain, even pain during bowel movements, infertility, and they're at increased risk for ovarian cancer, which is why most women with endometriosis, if they're like older in life, they end up just choosing to go ahead and get a hysterectomy done. But again, it's a really big deal for these patients to get. When we talk about our male reproductive system, again, a lot of structural issues are varicose. This is a medical emergency. The spermatic cord ends up getting twisted. And what does the spermatic cord do? It provides blood, nutrients, and oxygen to the testes. So if that gets twisted, the testes do not have any oxygen. So it's a really big issue. Okay? So they really need to seek help and get treatment. Our hydrocele, this is some swelling from a collection of fluid. And then finally our spermatocele, this is when we have some milky fluid being built up as well. Prostate cancer, usually these have a pretty good prognosis. They're really treated well, I would say. History is older men, inflamed prostate, issues with the BRCA gene, which you learned about in, I believe it was Dr. Vashovsky's cancer lecture, and it's diagnosed via our PSA test. A lot of our signs and symptoms are going to be urinary tract related, because if you go and look at the prostate, what does it surround? It surrounds the male urethra. So if it gets really, really swollen, it's going to essentially compress the urethra and make it a lot more narrow. So you're going to have a hard time using the bathroom. When we talk about our STIs, our most common STIs, we separate them into bacterial, parasitic, and viral. Essentially, what's happening with our bacterial, usually it's going to be our chlamydia, gonorrhea, syphilis, cankeroid. Sorry, I accidentally went back a slide. And you treat it with antibiotics. Our parasitic infections, that's when you have your scabies, reticulosis, trichomoniasis, and then our viral STIs are a little bit more hard to treat. You have your HSV, HPV, Hep B and C, HIV. So what are some complications of all STIs? A lot of it are more female-based: pelvic inflammatory disease, chronic pelvic pain, ectopic pregnancy, to name a few. So what's our goal for treatment? Safe sex, prevention for sure, frequent exams, etc. So now we are going to talk about our digestive system. So what's our main concern with diarrhea? It's going to be dehydration and fluid and electrolyte imbalances. So if I have specifically viral diarrhea, diarrhea caused by a virus, I'm at risk for hypovolemia. I'm going to have massive diarrhea that puts me hyponatremic and hypokalemic, simply because we're losing so much electrolytes. Acute, that's within 24 hours. Persistent, that's when we have it lasting 14 to 13 days. And chronic, we have longer than 4 weeks, which is a big issue, especially when you start thinking of skin integrity and nutrition, etc. So what can we do to help with diarrhea? We really need to replenish fluids. Most of them are self-limiting, but if they come in the hospital, we might need to give them fluid and electrolyte. Maybe do a banana bag for them. And then your brat diet, that is your bananas, rice, applesauce, and toast. That really is like very good for like if you're having frequent diarrhea. They're just bland foods and not a lot of like, it's just to help with that. Why is diarrhea a really big issue with pediatrics? Well, we talked about pediatrics have very small fluid reserves, so even if they lose a little bit of water, it's a lot to them. and it can actually lead to death with these patients. Usually it's going to be caused by rotavirus. And again, you assess for what are normal assessments for dehydration. That's skin turgor, dry mucous membranes, sunken eyes, etc. So we talk about our GI bleeds. If I have an upper GI bleed, I have bleeding in my esophagus, duodenum, or stomach. So if I am coughing it up, you're either going to see bright red blood or coffee ground blood. If you see bright red blood, usually that's like something from like the esophagus, such as esophageal varices. If I'm seeing this coffee ground blood, I probably have a bleed in either like my stomach or my duodenum, because what does the stomach do? It helps with digestion. So that blood's been a little bit digested, and that's why it's going to be coffee ground. So again, causes ulcers, varicose veins. What will we anticipate in the plan of care? What diet will we do for these patients? Either they're going to be NPO or they're going to be on clear liquids. What are we prepping them for? We're probably prepping them for some sort of oscopy, where we can take like a camera and we can put it down their throat and we can look for like an endoscopy, where we can kind of look for where that bleeding might be occurring. When we talk about gastroparesis, this is an issue with my stomach emptying, but it's not caused by an actual like obstruction. It's simply something's going on. It's not caused by a blockage. My stomach's just taking a little bit extra time to empty. Usually it's associated with diabetes mellitus, because remember, we have neuropathy. We have systemic neuropathy with diabetes. So just gonna have sensory issues with my stomach saying, okay, time to empty. Just gonna have some issues. So usually you'll see nausea, vomiting, abdominal pain, fullness, and bloating. I talk about peptic ulcer disease. These are little ulcers and stores in my stomach. Usually caused by frequent NSAID use or an H. pylori infection. H. pylori just loves to infect the stomach, and it's quite painful for these patients. Usually they'll have pain after eating, and it can be relieved by eating more or taking antacids, which seems a little bit contraindicated, but for whatever reason, when these patients eat more food, it just makes them feel better. Don't really know why, but it does. And then antacids, which are your Tums. Our main complication with peptic ulcer disease is that we could have perforation, which could lead to peritonitis and sepsis. So what as nurses do we need to look out for? We need to look out for fever and a rigid board-like abdomen. That to me is telling, if I see a rigid board-like abdomen, my stomach or my bowel just perforated and it's spilling into the abdominal cavity, and that is an absolute medical emergency. I know we talked in patients that are care a lot about diverticular disease, but just kind of lots of different causes. When we have diverticulosis, this is just the formation of little pouches. When those pouches get infected, that's when we have diverticulitis, with this inflammation that can be a little bit painful. Well, portal hypertension, similar to our pulmonary hypertension, is just increased blood flow, but in a different area of the body, specifically our portal vein. This is what helps remove blood from the liver. What does our liver do? It helps detoxify our blood. So I have portal hypertension. Almost always it's going to be caused by a liver issue, cirrhosis, fibrosis, etc. And our main complications, it puts me at risk for varices, ascites, hepatic encephalopathy. That is when ammonia and toxins in my blood build up because they're not being filtered out. What does the liver do? It filters blood. So if I have an issue where my blood is not filtering, then I'm going to have that buildup of toxins. And that is what hepatic encephalopathy is. You'll start seeing these behavioral cognitive changes because literally toxins are building up. Okay, you'll start seeing some subtle changes you'll start seeing maybe your patient was doing well all day and now they're just aggravated, sleepy, confused, they don't know where they are. I would probably want to get a full set of labs on them. We talk about neonatal jaundice. This is from the buildup of bilirubin. Bilirubin is a byproduct of broken down red blood cells. What's happening with our neonates, especially our prenatal babies or premature babies, is that their body still is just learning how to do everything, and maybe there's an issue with meeting demand, etc. But usually you'll see this yellowing of the skin and sclera on these pediatrics. It will subside on their own usually. It's pretty common. And we treat it with phototherapy lights. So let's talk about our musculoskeletal system. So we have lots of different ways we can classify fractures. I would pay attention to your complete fractures, your incomplete fractures, and some of your more pathological fractures. And then the ones in the top right, I think, are important as well. That's just how you guys can classify them. Rhabdomyolysis, again, another issue that's very common in patients that have had massive trauma or have had like surgery on like a long bone, multiple bones, or just like lots of sprains, strains, all the above. So what happens is when the tissue gets damaged, it releases all the tissue contents into the bloodstream that begins to build up. As all of these contents leak, well, what does my kidneys do? My kidneys help with filtering stuff, so it's going to lead to acute renal failure. So you'll see this increase in creatinine, a decrease in GFR, my CK, my creatine kinase level is going to be through the roof. They're also going to have lots of muscle weakness and tenderness, and they'll have tea-colored urine because simply they're like excreting all of this damaged tissue content. What I'm really concerned about with rhabdomyolysis is compartment syndrome in that extremity. So that's what happens when all this damaged tissue content leaks and it increases pressure in that muscle compartment. Keep in mind, not everyone with compartment syndrome will have rhabdo, but it's very common for someone with rhabdo to then have compartment syndrome. So really though, I would know that you need to assess for numbness, tingling, pain. Specifically, these patients are going to be in like rating 10 out of 10 pain. Even if they're like on a morphine, maxed out on a morphine drip, they're still going to be in a lot of pain. And if you go to palpate the area, you're going to have a very hard time feeling a pulse. And this is a medical emergency. Usually, I believe it's called a fasciotomy. The provider will have to physically like cut an area there to just relieve all that pressure. Osteoporosis, this is an issue with our bones where essentially we have this issue between bone reabsorption versus bone production that overall leads to a decrease in bone mineral density, which puts my patient at increased risk for fractures. So really common in our elderly population. This is why we need to promote safety, fall risk, etc., because their bones are very thin and very fragile. We just have a loss of our bone. That is all. Osteomyelitis, this is an infection of my bone. Usually it's caused by S. aureus, but any other thing could cause a bone infection. Lots of different causes: bites, needles, contaminated surgical equipment, all the above. Usually you'll see them with fever, pus, drainage, etc. What's kind of unfortunate with osteomyelitis is usually they're going to be on a heavy dose of antibiotics. It can be weeks or even months. They might even need bone debridement and possible amputation. With osteomyelitis, they might require 6 months worth of antibiotics, but they have to be IV. So usually with these patients, if they meet the criteria, meaning that they're not like, they don't have a history of drug use and that there's a safe place for them to go home to, we can actually send them home with a PICC line where they can give them their antibiotics themselves. So, other more common issues of the bones and joints are your osteoarthritis and rheumatoid arthritis. What I want you guys to remember with osteoarthritis, I want you to think of normal wear and tear, usually localized, symmetrical in the joint that's affected. Okay, it's not an inflammatory process. Rheumatoid arthritis, this is an inflammatory process, and it's from an autoimmune disease as well. So essentially, my body starts attacking rheumatoid factor, causing this inflammation. So that's why you'll see like systemic inflammation throughout the body, because it's a systemic issue. Osteoarthritis, just think wear and tear. Gout, this is when uric acid builds up in the blood. What happens is that as my uric acid levels build up, they form painful little crystals. These crystals end up depositing in places and cause inflammation. They usually deposit in the joints, okay, causing massive inflammation and pain. So some signs and symptoms, they'll have a hot, red, tender joint, specifically in the big toe. When we talk about diet, we need to decrease foods high in uric acid. So just review some foods that are high in uric acid and teach your patient to avoid those foods. Okay. Osteosarcomas, this is a bone cancer, and it is usually one of our more difficult cancers to treat, but it's really common in our knees, arms, and the long bones especially. Really diagnosed, we can biopsy the tumor, blood tests, etc. But just really know that it puts them at risk for fractures, fatigue, weight loss, etc. And it's pretty common in kids. Our major congenital defects, we have our club foot. This is when the foot actually rotates inwards. We don't really know what the exact cause is of this. However, we do know that like if moms have been smoking, this can contribute. If there's a family history, that might be a link too. But as you can see in the photo above, that's what clubfoot is. Developmental dysplasia of the hip is a little bit more common. Our hip is a ball and socket joint, so there's a lot that goes into play when fitting, obviously, the ball into the socket joint. So maybe the patient was like born breech and their foot came out first, and that kind of messed up the issue, dislocation, etc. But with DDP, I'm just having these issues with my hip. And there's a couple other ways we can test for DDH, but I would just know that they have like a difficult time with hip movement. We have up next osteogenesis imperfecta. This is our brittle bone disease. My bones are very porous. This is a genetic disorder that results in an abnormality with my collagen production. What are our complications? Osteopenia, bone deformities, short deformed teeth is a big one for these patients, heart failure, hearing loss, and specifically a blue sclera with these patients. When we talk about muscular dystrophy, this is a progressive disease, meaning it does worsen over time, and it is an issue with our muscles, not anything else, an issue with skeletal muscle. So what's happening is that these muscle cells just die, they turn into fat and scar tissue, which results in weakness. So they'll have essentially like all this muscle gets replaced with fat and connective tissue, and muscles are what help us do all of our movement. It's what helps me pick something up and bring it towards me. That's all muscle. So if I don't have muscle, I'm going to have pretty limited movement. We talk about Duchenne muscular dystrophy, same concept, except Duchenne's is caused by an X-linked recessive disorder, and usually these symptoms will start at age 3. Again, this is not a neurological issue, just a muscular issue, so they're not going to show any neurological deficits. Therefore, they should be treated, give them age-appropriate games to play. If you're caring for a 13-year-old, maybe giving them like a video game or a computer game, because again, it's not a neurological issue. They won't have neurological deficits. They'll just have this delayed motor development, maybe some muscle weakness. When the parents might notice that maybe at like 1 or 2, they're not really trying to stand, or they're having a really hard time sitting upright and standing, climbing upstairs, etc. So they're just not meeting the physical milestones per se. Again, when we talk about osteosarcomas in children, usually it is more of a genetic issue, specifically chromosome 13, but these patients will have a big bulky tumor that extends beyond the bone. And unfortunately, these are one of the most lethal tumors as well. Multiple different types of scoliosis. You have your congenital, tetralogic, non-structural. So we have our C curve, our S curve, etc. We have structural scoliosis. The difference between non-structural and structural is non-structural means there's not a problem with the spine itself. Maybe that their pelvis, there's an issue with their pelvis that's causing them to be curved. So we treat the underlying condition. Now, structural scoliosis, that is a specific deformity of my spine. Therefore, I treat my spine with surgery. Okay. And then just review your thoracic, your lumbar, and your etc. So we have Ewing sarcoma. Again, unfortunately, a lot of like our bone cancers have poor prognosis. So this is usually a cancer of the femur or sacrum. Common in 10 to 20-year-olds. Again, chromosome issues, but with Ewing sarcoma, this is 11 and 22 get translocated. Lots of complications. This is a very high risk for metastasizing, specifically to the lungs. They're going to have a lot of pain at the site. When we're talking about more like connective tissue and integumentary, this is our discoid lupus erythematous. This is our inflammatory autoimmune disease with skin manifestations. So usually the triggers are going to be UV light. That's a big one. So like tanning beds, sunlight, etc. They're going to have photosensitivity, specifically this butterfly rash over their nose and their cheeks, painful swollen joints, and some other plaques. So what can we do for treatment? Well, it's an autoimmune disease. So if my immune system is causing the problem, I need to suppress my immune system so I can give immunosuppressants and steroids. What else am I also going to do? I'm going to teach them to avoid their triggers, avoid sun exposure, avoid UV light, smoking, all of those things. So, scleroderma, another skin issue, but essentially I have way too much collagen production, which causes tightening of my skin. While it's this tightening of the skin, if it's localized, not the worst problem. It can be uncomfortable. I can have some cuts, some strictures. When we start getting concerned is when we have systemic when we're having a systemic issue, because now it's affecting the organs, okay? And now if my organs are thick, they're not functioning as well, okay? Can also lead to sclerodactyly, Raynaud's phenomenon, etc. Now we get to talk about burns. Just know that with your 1st degree burns, those are more your sunburns, okay? The 2nd degree, we're still in the dermis, but maybe a few more layers of the dermis. Our 3rd degree, that's when we go below the dermis to the hypodermis. It does take a long time to heal. Our 4th degree burns, this is full thickness, and these will not heal on their own. They might tunnel, but they're not going to heal. So this is when we would need skin grafts. And I want you to know that no matter what, with burns, we're concerned for dehydration, hypovolemia, hypotension, okay? Staging pressure ulcers. Pressure ulcers are very common and we want to prevent them in the hospital setting. How do we do so? We do so by like putting some pillows under bony prominences. We turn them every 2 hours, or we get them up to chair or chair to bed or up walking around the hallway. Whatever we can to relieve pressure on certain areas. So if I have stage 1, my skin is completely intact, but I'll just see redness that's non-blanchable. If I have stage 2, just affecting the dermis, okay? Partial thickness loss, but still the dermis. If I have a 3rd degree pressure ulcer, now subcutaneous tissue is getting involved. 4th, that is when I can now see muscle or bone, okay? It's gonna tunnel. And finally, unstageable. This means that my pressure ulcer is covered in slough or eschar, meaning I can't see how deep the wound is because it's covered in something. So that's what we call unstageable, meaning I simply can't stage it because I can't see where it's going to. More common skin issues, you have your HSV, herpes simplex virus, HSV1, that is our like cold sores, mouth lesions, etc. This is transmitted via infected saliva. Our HSV2, on the other hand, that's our genital herpes, can transmitted by sex or by birth if a child was born with someone with an active HSV, vaginal birth, etc. So, more skin issues. We have varicella zoster. That's our chicken pox. Okay. It is again caused by one of the HSVs. But really, with this one, how is it transmitted? By touching the blisters, mucus, saliva, etc. What is herpes zoster? So, in order to get herpes zoster or shingles, you've had to have had a chicken pox infection. So what happens is with herpes zoster, the varicella zoster remains latent in our dorsal root ganglia. And again, it gets reactivated usually in times of stress or altered immunity. And that's when you're going to see this painful rash along the side. It's not going to be like the vesicles and blisters. You're going to see this really painful rash, okay? Again, brought on by exacerbations and stress. Up next, we have hives. These are a type 1 hypersensitivity reaction to specific allergens caused by the release of histamine. You might see some wheals, rashes, etc. But again, this is type 1 hypersensitivity reaction. Candidiasis, this is a yeast-like fungus. Oral candidiasis is the most common, usually related to inhaled corticosteroids or patients with suppressed immune systems. But they'll have this whitish curd on their tongue, and while you would think you can scrape it off, you can't. So how do we help the patient with this? They have like swish and spits or swish and swallows to help kind of with that. So what are some risk factors? Systemic administration of antibiotics, pregnancies, diabetes mellitus, and Cushings. All right, so that is all I have for you guys. Just a friendly reminder, on Saturday at 3:15, we will be doing practice questions. It's going to start at 3, but just so people have like time to log in and get set up with the Kahoot and everything. But yes, we will be doing some practice questions then. Does